Up next is Dr. Pamela Chavez. Dr. Pamela Chavez is professor of ophthalmology at the Medical University of South Carolina. She's the director of Neuro-Ophthalmology Division at the Medical University of South Carolina Albert Florence Storm Eye Institute. Dr. Chavez is no stranger to this part of the world. She was the chief of neuro-ophthalmology for 13 years at King Khalid Eye Specialist Hospital in Riyadh, so much so that she offered to give her talks in Arabic. Many people in the attendance probably know her, and her experience and insight into neuro-ophthalmic disease in this part of the world should be of great value. Dr. Chavez's interests, other than neuro-ophthalmology, includes uveitis, and she wrote a lot about Behçet disease, which is something that we see commonly here. She will be talking to us about mimickers of optic neuritis.
Thank you, Raid. It's really a pleasure to be here and to be back in a region where I've spent so much of my time and left so much of my heart, and a pleasure to see some of the residents that I knew over a decade ago now. But unfortunately, if I gave my talk in Arabic, it would be strictly in the present tense, and the vocabulary would be very shwaya. Anyway, well, you know what? I am a neurologist and an ophthalmologist, and so the mimickers of optic neuritis are very, very important to me. And I thought it was a great topic and really a fun topic to deal with. So I am going to start from go on this as well, and I'm going to talk about the typical optic neuritis. That is, young females with sudden visual loss that have progression of symptoms over 1 week or less than 1 week. And really by that I mean over the first 3 to 4 days they may get worse, but usually by 5 they're stable. If they're still having symptoms getting worse by 7 days, I'm getting very nervous. This is not typical optic neuritis. Their visual improvement usually begins by 1 month. The disc may be normal or swollen, as Peter said. There may be a few vitreous cells, but usually not very many. The visual field defect is central scotoma or an altitudinal defect. Usually they have no history of systemic disease, and Andy Lee is going to tell us about the systemic diseases that can present like optic neuritis. And the MRI is probably abnormal. And we're used to expecting that a DR2 antigen is common in people from Scandinavia and is more linked to optic neuritis than in other areas of the world. So demyelinating optic neuritis. Well, the key to the other kinds of the non-MS syndromes is a combination both of the clinical presentation and the MRI presentation. So MS DR2 versus post-viral, post-vaccinal optic neuritis, acute disseminated encephalomyelitis, and DeVix or neuromyelitis optica. So let's start with acute disseminated encephalomyelitis, or ADEM. Well, acute disseminated encephalomyelitis is really multifocal or disseminated, and it's the meningoencephalitis with a big encephalopathy as part of it, which really means to us that the patients are confused and they have altered mentation when they come in, unlike the usual MS patient. It is multifocal, so it's also polysymptomatic at its first presentation. This can be post-viral or post-vaccinal or not. And the patients are often less than 10 years of age. It's usually a one-shot high hit and with a lot of lesions or monophasic. And as part of that, they can have a bilateral optic neuropathy. The CSF can have a lot of cells, but usually without glaucoma bands or very few. And the MRI lesions are typical. They're big. They're all the same age, and they're all enhanced with gadolinium, and their borders are all a little bit fuzzy with inflammation. So when we look at ADEM, what we're looking at is patients getting these symptoms usually around 7 years of age, as compared to MS, where the symptoms are in childhood, usually in the preteen and teen years. The male association is a little bit more with ADEM than female with MS, and ADEM again is quite acute and apoplectic in its onset. And you know, MS kind of smolders along for a while, and parents will tell you that the child's been complaining of things for some time. A rash, a vaccine can be the part part of the presaging scenario for ATEM, and a URI can occur with either. And again, ATEM is polysymptomatic. The encephalopathy is big with fever, seizures, meningeal signs, and multifocal signs. And a retrobulbar neuropathy and a myelopathy can be either in ATEM or MS. So what else helps? Well, cells in the spinal fluid. A lot of cells in ATEM. It's an acute disease, an acute inflammation, and they'll have more than 100 cells. And we're used to seeing a few cells in MS acutely, but not very many. Oligoclonal bands are certainly part of what we expect in MS. They are either not present or very slight at the beginning with ATEM, and they tend to disappear with time. And protein, as part of this diffuse inflammation, is very high in ATEM, and is certainly not in MS. ATEM should last 6 months or less. And if you have a relapse, it will happen as steroids are arbitrarily tapered. Patients may worsen. And we just heard about steroids in MS, and I won't go through that again. And we saw a picture of the lesions in ATEM. They're big. They will be in the white matter, periventricular, and they'll also be approaching the gray matter. They are all the same age. They all light up with gadolinium. They're bunches of apples and oranges and grapefruits in the brain, and they are all the same as far as enhancement. They usually resolve, and occasionally the patients become normal. And the lesions in MS are ovoid. They tend to be around the corpus callosum. They're new and old, so some light up with gadolinium and some do not. And some old ones have left little T1 holes in the white matter, and so it's a very different look to ATEM and MS. Well, this was a patient with ATEM, and this young man had enhancing lesions in the periventricular thalamic area and deep white matter, and over the course of time they resolved, and his brain MRI became quite normal, which is quite typical for ATEM. But sometimes ATEM is a little recurrent, so then we have a bit of a challenge. And a new ATEM event can happen about 3 months after the first. Usually it's an old lesion that was small, and as the patient is treated and the steroids are withdrawn, that lesion recrudesces and new symptoms happen from it. That's usually where it is. There's an entity called multiphasic ATEM, and I don't think I'm sure what that really is, and whether or not that's really ATEM or whether or not that's some bridge between ATEM and MS. But multiphasic ATEM means that there are new lesions, they weren't on the original MRI, and they're occurring rather late in the course. So time will tell what that really is. Well, what does ATEM look like? Well, there are perivenular confluent white matter lesions in ATEM, and they're enormous. Look at the shift of the lateral ventricle across the midline, and they really are extensive through the hemispheres and through the cerebellum. So because of that, ATEM is treated very aggressively. IV methylprednisolone or IV immunoglobulin in the usual high doses that we use, and starting with IV steroids, adding on IV immunoglobulin, and then plasmapheresis by day 5, and for the next 4 days, and with both IVIG and steroids, and eventually tapering off to a steroid taper. And this last patient I'm going to tell you about was a patient who presented, and his initial lesions with ATEM looked just like the ones we saw before. Then we have these perivenular confluent white matter lesions. Here we are, baseline, looking at his pons. It looks quite pristine. A month later, it looks fine. A year later, there's a new lesion here in his pons cerebellar junction, and by 3 years, several. So this was a patient with typical ATEM who could be called multiphasic ATEM, but certainly became MS. So, what else about ATEM is important? Well, bilateral optic neuropathy may not be specific for ATEM as a post-viral or post-vaccinal event. And we can see bilateral optic neuropathy post-vaccine without the rest of ATEM. And if you look at the incidence post-vaccine, it's about 0.1 to 0.2 per 100,000, and it occurs with any of the vaccinations. But the big ones are measles, mumps, and rubella, and all the rest are also RANs. And the encephalomyelitis that you see post-vaccinal looks rather similar. The only difference is that, again, this tends to be around the third ventricle and deep white matter, gray matter junctions, as opposed to some of the more typical MRI lesions. And that brings us to talking about Guillain-Barré syndrome, which is also a post-viral phenomenon that can be associated with bilateral optic neuritis. And as part of the C. Miller-Fisher variant of Guillain-Barré, or Guillain-Barré itself, you can get supratentorial white matter lesions that look just like ADEM. And the key here is just that it's different in that there's a ascending peripheral neuropathy with this that is not with the other. And so it's haphazard for the patient. The other demyelinating optic neuropathy viral association that I want to talk about is Epstein-Barr. And there's a recent paper suggesting that latent EB virus is linked to relapsing remitting MS. And if you look at antibody loads to EB virus, nuclear antigen IgG, the higher antibodies are, the more lesions there are in MRI on the brain. So that's very, very interesting and important. And we always associate a few viruses with MS, and EB virus has always been one of the ones that we do. And so now we're starting to see some papers come out suggesting that there is some true association between some of these viruses and expression of MS. And the theory is that the T-cell responses to the EB virus cross-react with myelin. And again, we may be seeing some molecular mimicry, as we've seen in other diseases that are white matter and demyelinating. All right, well, let's try a different scenario. Let's try bilateral simultaneous optic neuritis, and the MRI is normal. And so the first thing we think about here is de Vick's disease. And so classically, de Vick's disease is an optic neuritis or papillitis with an acute myelitis. And the brain is usually normal on MR, and it's uncommon to see MRI white matter lesions. This is one that can be present, and they can be small like this, but they're usually not much more than that. And the key to de Vick's is that you have demyelinating lesions in the spinal cord that go more than 1, 2, 3, here we are at 4 segments, so more than 3 segments of spinal cord demyelinating, and that makes it de Vick's. In fact, the major criteria for de Vick's are that the brain is normal or nearly normal at onset, and the spinal cord segments are what they are, and there can be a CSF pleocytosis that can be rather moderate at about 50 white blood cells per cubic millimeter. There are minor criteria for de Vick's, and optic neuritis comes in there, either bilateral or unilateral, and with less of a paraparesis and more monoparesis. De Vick's is really often linked to an antecedent virus and is usually, fortunately, monophasic. But not so fortunate always for the patient, because de Vick's patients do worse initially, and many of them have relapses over the course of time. And when you look at any group of de Vick's patients, you're going to see some that are bilaterally blind from the first episode and cannot walk, and some have respiratory problems from the cervical myelitis. De Vick's we treat very aggressively, and azathioprine and today rituximab for its B-cell effect is really important in treating de Vick's, and or plasmapheresis. I'm not going to talk too much about Sjogren's or autoimmune problems. Andy's going to cover those later. The last thing I want to mention about de Vick's is that, we're very lucky. We have a blood test for it today in the neuromyelitis optica IgG antibody test and through Mayo Labs. And this test is specific for an antigen called aquaporin 4 that's a central nervous system white matter channel antigen. And when we look at the lesions in de Vick's, the ones that occur, are around the ventricles. And these are areas of the brain that are laden with aquaporin 4. So the inflammation there triggers the antibody that we later can pick up in the blood. So the test is a great test to have. All right, well, let's take another scenario. Let's take the brain is normal, but the patient, again, has retrobulbar neuritis, neuroretinitis, or papillitis. I'm going to just go through these a little bit quickly. And reevaluate papillitis if there are other signs and symptoms. That is, if you see cells in your spinal fluid and rather cells in your vitreous and if there's a macular star, or if there's subretinal fluid, or if you see a retinal vasculitis anywhere from the mid-periphery to the posterior pole, reevaluate, because that's not typical optic neuritis. That's something else that looks like it, or typical papillitis MS. One of the first things we think about is so-called Leber's neuroretinitis. And this is acute visual loss associated with the URI in children. They have disc edema, they have subretinal fluid here, and torpedo-like exudates in Henry's neurofibrillary in the macula. As neuro-ophthalmologists, we're always happy to see this if we believe that this is post-viral, and because we suspect that these children have a low rate of progression onto MS. But we always remember that there can be other things that can present with the neuroretinitis, and from cat scratch to Lyme to syphilis to tubulointerstitial nephritis and uveitis, multifocal retinitis, toxoplasmosis sometimes, leptospirosis, and if bilateral Haradas, Rift Valley fever, and immune recovery uveitis. So this is a patient from Saudi Arabia that had bilateral VKH with a papillitis and ILM folds in the retina going to the macula and subretinal fluid, and then another patient with diffuse choroiditis. So always remember VKH. And what else? Well, MS and optic neuritis, but a peripheral vasculitis is part of the MS picture. And this vasculitis is way out in the periphery. This is a tough picture that the photographer got. We're at the end of the vascular arcade. And that's the only place in MS that you're allowed to have chorioretinal lesions. Anywhere else, it's not MS. You can in MS have an intermediate uveitis, but chorioretinitis only in the far periphery. So as part of your optic neuritis papillitis exam, you have to do a careful fundus exam, because you have to look for other reasons for a papillitis to have to be there, and that means you're looking for other fundus pictures, and you might be looking for in TB for choroiditis associated with the papillitis that is typical for TB, or Eales disease with a retinal vasculitis that can look even like sarcoid, or toxoplasmosis with a cloudy vitreous and a papillitis. So the fundus exam becomes very essential. Other reasons for papillitis with retinal vasculitis include Behçet's, as I mentioned, patient with a papillitis here and arteriolitis, and this patient with syphilis and optic neuritis, and Lyme has a similar appearance. And toxicara, which we don't see very much in the Middle East, with a granuloma of the optic nerve can also present like this. The last one in this group that I'm going to mention is so-called papillophlebitis. And this looks ugly. The disc is swollen, the vessels are really grossly distended, and it looks terrible. The patient sees just fine. They may notice a few floaters and have a little blurry vision, but they're not unhappy, too unhappy anyway. We look and we get very upset. But papillitis has a rather benign scenario. These patients resolve, they do well, and there's usually no sequelae from it. It's probably another post-viral event. The last group that I'm going to talk about is the patient comes in, they have visual symptoms, and they have visual signs like temporal pallor. And you look at the MRI, and there's white matter lesions, and you're saying to yourself, is this an old retrobulbar neuritis? What am I dealing with here? And if this isn't bread and butter neuro-ophthalmology, what do I do from here on? I don't know what is. And when we talk about temporal pallor, we're talking about this part of the disc, obviously, and we see nice hyperemic normal disc here. And when we look at this temporal part of the disc, there are less than 9 to 12 little capillaries that we can see here. And in fact, the neurofibrillary layer looks pretty inapparent. And to see this better, I always look with red-free light. But in any event, so there's clear temporal pallor. So temporal pallor, blurred vision, neurological signs and symptoms, and you do the MRI and you see some white matter lesions, and where do you go? Well, one patient that we had came into us at 54 years old. She was complaining of visual blurring, lots of neurologic complaints. Right disc, maybe you could pass that as okay, but clear temporal pallor in the left disc. and she was insistent. She had just a lot going on. Her MRI showed a lot of white matter lesions, and her FLAIR showed those and a few more. But her diffusion-weighted imaging was quite dramatic. And our very smart head of the MS clinic suspected Cadocil and cerebral autosomal dominant encephalopathy. And in fact, this is a dominant inherited phenomenon with periadventitial changes and extensive white matter changes. But you know, our patient was somewhere before this, and so it was not quite as apparent to us when we saw her. So Cadocil is important to think of because these patients sneak into MS clinic, and we could miss them if we didn't think of them. What about migraine? You know, isn't that the MRI report we get back? Non-specific white matter changes, could be migraine, could be other, and then you're left with trying to figure out what it is. Well, there's an interesting paper that just came out, and it talked about migraine with aura in midlife women. And what it said is that women who had years of migraine with an aura, when you look at their MRIs later, they not only have cortical changes, but some have subcortical white matter changes, and a lot had cerebellar changes that could be small, could be greater, but that this was really part of their migraine phenomenon. So having seen this paper now, I might feel a little bit better about not relegating these patients to a new disease and being content to say perhaps this is just migraine expression in midlife. The last thing I want to talk about is mitochondrial disease, and this is again the patient who comes in with temporal power, and you do a MRI and you see white matter lesions, and what you must not forget is that the mitochondrial disease, whether it be Leber's or current Sayre's, can present sometime before they are so pathognomonic with just deep white matter lesions. One of the good things to remember about some of the encephalopathies is that certainly there are a lot of other signs that we can use to hang our hat on, but sometimes, especially with the young men with optic neuropathy, the key is really deciding when it's Leber's and when we should work the patient up for Leber's and when we should be content with MS as a diagnosis. I would offer some of these additional tests, and what you have to do is you have to look at your atypical optic neuropathy, decide where in the spectrum of diseases do you think this is most commonly going to be resting, and then consider the testing that will help with that, whether it be NMO for DeVix, anti-GQ1B antibodies for C. Miller-Fisher variant, toxoplasma, interferon gold for TB, or whatever, to help you make your diagnosis based on your clinical exam. That's really all that I want to talk about for this. And I'm sure I forgot something, but I'm not sure what it would be yet. Thank you.
Dr. Satowski is next. Thank you, Dr. Chavez.